Okay, so it's 8:30, so I'm gonna get going. Thanks for showing up on an 8:30 on a Friday morning at SAEM. We really appreciate the interest. My name is Dave Liu, and today we'll be talking about what are you doing after graduation, insights from the ABEM in-service exam about the career plans of U.S. EM residents. Again, my name is Dave Liu from UW. Our speakers and panelists today include Chris Bennett from Stanford, Michelle Lal, the Vice Chair of DEI and the President now of SAEM Board, no longer President-elect, Dr. Calderon from the Chair of Jefferson, and Mark Courtney, the Vice Chair of Academic Affairs at UT Southwestern, and Brian Kane from the High Valley and the APD and past President of the medical staff as well. So the only disclosure is that Dr. Calderon serves as the ABEM Board of Directors, and we collaborated with ABEM to get our data. Otherwise, we have no other disclosures. So at the end of this talk, you're going to be able to know the career plans of graduating US EM residents. You're going to know which factors were most important to them when considering their career plans, and then you're going to be able to discuss the future of the EM workforce through the lens of a recent cohort of EM residents. And I'll turn it over to Chris now to review the data, and then afterwards we will have a Q&A session with the panelists as well as the audience.
All right, friends. So what Dr. Liu mentioned is this is basically a cross-sectional representation of data from the 2023 ITE. It's a survey of graduating residents. So as you know, that's going to be third years and three-year programs, fourth years and four-year programs. There are around 2,700 respondents, and the response rates for individual questions posed range from like 78 to 86%. In addition to containing information, voluntary self-reported aspects of demographic characteristics, the survey also asked questions about burnout, thoughts on career regret and plans, factors driving these career choices, and their thoughts on attrition. Said differently, how long they would practice, and also when they were going to leave, what that practice would look like after being a clinical emergency doctor. Simply to say here, you can see that the majority of respondents identified as male and as white, and were from PGY 1 to 3-year programs, which is consistent with known information about the demographics of the current resident workforce. So somewhat, actually quite representative of the workforce overall. When you look at the distribution of debt, which I will say is there are a couple of different options, but the bulk of the respondents had debt anywhere between $200,000 to $400,000. And when you ask the questions of patient level, professional level, and personal level burnout, the majority, around 72% of respondents, had some degree of burnout. The caveat being, asked the same question, would you do it again? Around 73% of respondents would become an emergency doctor again. When you ask questions then, what will you do after residency, either plan or intent to, you see there are a number of different options, with the majority, at least the bulk of residents, responding that they plan to go either in community, followed by a fellowship, and then in third, some degree of a hybrid option between those two. With regards to where you'll practice, not necessarily the type of practice, the majority of respondents had ambitions and or intents to go into more urban environments, compared to only a smaller subset who had reported interest into being into a rural environment. For orientation purposes, for those of you who have not seen a forest plot before, this is essentially a visual representation of a series of comparisons looking at the relationship between choosing a rural or an urban environment. Said differently, these are visual plots, odds ratios, 95% corresponding confidence intervals, using a multivariable logistic regression model, using a couple of predictors that we thought were interesting, but also those that met some degree of pre-specified criteria like a beta of 0.1 or p-value of 0.05. Suffice to say, when you ask the question, the likelihood or the odds of choosing a rural over an urban environment, you see that the individuals who had the least debt were more likely to have identified as going to practice in a more rural environment compared to those in urban, and that's like 25 to 40% higher in terms of the odds. And then, those identified as white had a similar relationship. Conversely, those that were respondents from 4-year programs were the least likely to consider going into a rural versus an urban environment. Taking a step back here from a forest plot and looking at a forest plot, so you can see there's a little bit of slant to the right, and on the bottom left there's a slant to the left. And so this is a quasi-Likert scale from no influence to strong influence, and these are factors that are driving career choices. So those in the top right are the factors that are going to have the most influence on an individual's decision to choose, and you can see things that make some degree of sense. So lifestyle, geographic location, professional fulfillment, and salary expectations. And on the bottom left, the thing that I'll draw your attention to, things that had relatively minor to no influence influence. And those are things like the COVID-19 pandemic, the projected surplus that we've all heard about before, and as well as questions like competitiveness or prestige. When you take those factors from the forest plot and you ask similar questions looking at the odds of an association of whether lifestyle was or was not a choice of consideration, location was or is not a choice of consideration, you don't see much in the way of crossing significance, so nothing that really stood out in regression modeling. But when you start asking questions of whether you would choose mentorship role model versus not, and salary versus not, you see a couple of things that stand out. In particular, probably the most interesting relationship in the top right, you see is increasing debt has an increasing relationship of choosing salary. Said differently, respondents who had a higher amount of debt had a higher odds, and sort of relationship-wise progression of wanting to choose a job that had a higher salary compared to those with lower debt. And the same thing with regards to looking at family expectations versus not, competitiveness versus not. Some things that were to the left, some things that were to the right. Individuals who identified as female actually had a decreased odds of choosing family expectations as a factor where they would practice or how they would practice. And similarly, in terms of competitiveness and prestige, 4-year respondents were more likely to choose it compared to their referent PGY 1 through 3 colleagues. When looking at burnout and professional fulfillment, similarly, a couple of things that stood out. The relationship that I'll mostly point to is in terms of burnout. You see, interestingly, those that had a higher score on burnout, or those that were more burnout, were actually less likely to choose burnout as a predictor in terms of their practice. And that's a conversation piece for a lot of us, Stockholm Syndrome or not, but it was something that we didn't necessarily expect. And in professional fulfillment, we noticed that individuals who had self-identified as female were more likely to choose professional fulfillment as a factor driving their career choices, as well as those actually with burnout as well. Another forest plot here, again, this is going to be a binary, so checked or not checked. What's mostly going to be of interest to you is on the right side, the green, not the gold. And so essentially to say, like, when you plan to cut back, what are you going to do? Many individuals just commented they were going to retire flat out, whereas some had some degree of an options where they do a non-traditional path, and in several subsets of individuals talked about going into attrition. It's with the expectation that, at least looking at measures of central tendency, mean, median, the majority of people at the time of graduation had an expectation to practice for about 20 years. Individual data is across the board, there's some distributions, but for the most part, most people have planned on practicing for a solid 2 decades. I'll pause for that because it's a lot of forest plots, but having said that, I do want to save some time for the panel discussion.
Thanks, Chris. So we're going to open up some of these questions specifically to panelists, but if there are questions from the audience, feel free to raise your hands and then we can answer those as well. So the first question, what was surprising and not surprising about this data for you guys?
I can start. I think one of the surprising things was the amount of individuals that said they were going into fellowships. And I have to say, I wonder if it was a combination of, or more of a 1 to 3 program versus a 1 to 4 year program. So I found that a little bit surprising. But that said, I think that's part of the reason why ABEM has been working hard on looking at these different types of fellowships and creating certification processes for that. So.
Yeah, I think one of the other things that was really interesting is that even those identifying with burnout didn't plan to leave any earlier or change. And Dave and I were talking about this a little bit yesterday. I think we're going to continue to see a shift because we have very much socialized the concept of burnout in our field, in our specialty, right? We have TV now socializing it for us to the public. But I think as we have done that, people recognize that while, yes, that may be a downside to the specialty, it is just a reality. And I think this approach of coming in kind of eyes wide open from a student perspective, that the things we do are hard. But the flip side of that is that the things we do are rewarding, right? So that chart hasn't really changed in a long time. I forget now, might have been one of Shanafelt's original papers, right? EM was that big outlier with the super high burnout, but the super high work-life balance satisfaction. So it was weird to see, but then kind of in thinking about it more, maybe it's actually not that surprising that like it's just sort of become like we socialize and accept that burnout is part of what we do. Burnout is also kind of transitory, right? Depends on when you survey any of us where you're going to score on a burnout instrument. So if you've just done a huge stretch of shifts, your burnout's probably quite high. But if you just had, a week where you only had 1 or 2 clinical shifts and they went really smoothly, your burnout's probably pretty low if you were to retake the instrument. So I thought that was really interesting. Yeah.
I think to your point, just to add a bit to your point, is that we're with the discussion of burnout, there are more interventions that are being put in place within our residencies and within different departments. And I do think, the general resident does see that there is a real emphasis of not only discussing it, but also intervening.
So for me, one of the things that I'm still trying to get my brain around had to do with longevity of practice. Just based on those numbers, this should be the last thing I do in EM, and I'm done, drop the mic type thing, based on my age and number of years. But in my lived experience as I just finished a stint as president of our medical staff, a little over 2,000 physicians, 11 hospitals. So I'd have a lot of conversations with our C-suite about kind of business planning around workforce issues. And they're now trying to get their brains around how to think about assembling a workforce. And the data they were focusing on in one of our more recent discussions is in the ambulatory space, where they estimate that about 80% of their ambulatory physicians will only work in 80% FTE. So what does that look like? That what productivity is going to look like in the next 10 years is going to be very different from the previous 10 years when you think about what physicians do. And that is going to significantly impact the view of things from the C-suite level. And what does that mean?
I think what was not surprising in some ways was debt. I mean, I think we're seeing some self-reported data here on debt that matches what we are hearing from our individual resident graduates that is significant in terms of their well-being, their future, their choices, their autonomy. So I think that's not surprising, but it's important to see, look at, recognize, and appreciate. I think that, and I'm going to kind of build a little bit on what Brian said. What's missing from some of this is just as important as what is shown, right? This is self-reported intent data, so this is not necessarily, exactly where they're going to be for sure, or exactly, what their final landing place for sure will be, but it's as good as we can get for that stage in the life of these individuals. And there is some actual missing data, non-response too. So, self-report data and also intention of looking at the future data has always got to be thought of, and a little bit of a caveat. The surprising thing for me is the rural data, I think. I found it surprising that it seemed like, and Chris can tell me if I'm wrong, that the debt and the salary is kind of flipped from what I would have thought it would have been. I would have thought that if you have high debt, you may be more likely to go into a rural place, and maybe you're going to get a higher salary to be in a rural place. That doesn't really seem like that's what the data showed. And that means maybe, there's not market forces in place yet that are attracting people to areas where we need more emergency medicine physicians. Now, that may happen in the future. I don't know how long that will happen, and I don't know what the magnitude of that force will be in terms of people's decision making, because it seems like they're driven by an awful lot of other things.
Mark, just because you brought up the urban-rural, that's one of, for me, the big take-homes. So I went to med school at an urban med school. I trained at an urban residency. I've worked primarily at urban, suburban institutions. But the system I described earlier, we have a number of low-resource rural sites, and our ability to locate and recruit board-certified emergency physicians is so difficult that I had to have my name on the bylaws revisions where we said it's okay to work in the ED and not be boarded in EM. So when we think about workforce issues, what does that mean to us as kind of the premier group of academic emergency physicians in the country? And we're thinking about training, and how do we envision a world in which the pipeline that we work with produces physicians that are seriously thinking about spending some portion of their career in what is often a low resource setting. And I know ABEM weighed in on that recently to a degree.
Touching back on what Courtney and Brian mentioned, so this is self-reported data, right? So in our data, the typical senior resident who is graduating in 2023 said that they expected to practice for about 20 to 25 years. Whether or not in reality that ends up being the case is unclear, and it seems to conflict with what data Chris has published before in terms of what happens in the real world. But nevertheless, the question is this concerning for us as a specialty when the average EM resident who is graduating says they plan to practice 20 to 25 years?
I mean, I think you can look at it either way, right? If that's what they're thinking right now, that's reassuring based on data we've seen. So I think you could really see it as a positive. One of the other things I wonder, and we didn't talk about this in this talk and we don't have data for it, but just anecdotally, I do think the average age of graduation at residency is increasing and has been over like the last couple of decades. So if we have more folks that are finishing training around 30 than we used to, then maybe going to 55 is pretty accurate expectation of where you expect to go. And I think it seems like, at least from the data Chris has done and Mark, some of your work, that if we can get people past about 10 years, they're going to stay. And so how do we focus, future efforts on that? Like getting them over that big hump so that then they'll stay in for maybe what is actually another 20 years or more.
Yeah, I think it's a really provocative thought, and it's also just hard for me to get my head around the future on this, right? I mean, if you look at what has happened in the last 20 to 25 years of emergency medicine with respect to the variety of practice settings that people can do while they still are full-time, while they still are working shifts, what some subspecialty type effort has looked like in terms of addiction medicine and a variety of other things, or graduation beyond the ED into hospital leadership and things like that. It is pretty astounding just looking in the past. So looking in the future is really hard to think about what that might be. The question for us, I think, is how do we, as the leaders of this society and as the leaders of our field right now, do things to help get us to where we need to get to take advantage of opportunities, to define what emergency care looks like beyond just what we do right now. That's going to require cooperative effort, and it's going to require some imagination and some creativity, some drive, some motivation that, maybe this cohort has a significant amount in this group of folks. So those are kind of my thoughts on that. It's overall hopeful, but it's also filled with, I think, a lot of uncertainty.
Mm-hmm.
I think I would add to that this is an opportunity for organizations like ABEM, SAEM, and the rest to really get together and have the conversation of how we make the value of our certification, the value of our practice, and really get that message across to our residents and our early faculty, our young faculty. I think that really, I think together all the organizations want that. They want the practice of emergency medicine to be a practice that people appreciate and that we're also caring about their wellness. Mm-hmm, so. Mm-hmm. It's a good conversation point.
And to jump on something that Mark alluded to, I got sent a credentialing and privileging form for one of our graduating PGY4s, and in the delegation of privileges paperwork, there was the core EM bundle, and then there was the telemedicine bundle, and it was already built in, and I had to send an email back to the hospital to say, which one has my resident picked, or did they pick telemedicine, or then there was also addiction medicine at the bottom. So as a specialty, I really do feel like we're at kind of this asymptotic inflection point where in the next 5 to 10 years, things may look very different. Again, at the C-suite level, leaders are struggling year on year. Now it's almost month on month. What are insurance companies going to reimburse? What's going to be an admission? What's going to be an observation? How are you going to work on your 30-day readmission rate? And what's the role that EM is going to play in these bridge clinic type settings or prevents bounce back settings? ABEM now has I think, at least from my perspective, astutely made some statements about including observation medicine as part of training. What is that going to then do to the portion of our workforce that I'm only going to point at me and I'm making no eye contact with my fellow panelists? When you're old and decrepit like me and working past midnight is difficult, there never used to be options, but now there's a panoply of them. And what is that going to do to that last act of the play, as it were, of your career? And I don't think we know yet. It hasn't been written.
We're actually at time. We have a lot more questions, but feel free to come up to us with any questions that you may have. But thank you for coming on Friday at SAEM.
Thank you.